So my name is Elizabeth Baltenberger. I am one of the clinical pharmacists here at Eastern State Hospital, and today I'll be talking about opioid dependence treatment in the inpatient psychiatric setting. Our learning objectives today are to describe the prevalence of opioid use among people living with mental illness in the United States, describe Eastern State Hospital opioid treatment practices, and identify evidence-based opioid treatment recommendations for the inpatient psychiatric setting. So first I'll go over some demographics for opioid use disorder. In 2024, there were almost 8 million people misusing opioids in the United States. That's nearly 3% of the population. And 7.6 million of those people were misusing prescription opioids specifically. Now, this has declined from 8.5 million in 2021, so we're going in the right direction, but it is still a significant issue. The chart there on the right shows a breakdown of different prescription opioids that were misused specifically in 2024 for people 12 and older. You can see there at the top is buprenorphine, then methadone and prescription fentanyl, and on down. I really like this graphic because it does break down Kentucky into the different CMHCs that we service. So you can see there our different catchment areas. So in the middle there, number 3 includes New Vista, where we are, along with North Key and I believe Comprehend. Now, if you look at the numbers there, the percentages across the board, they are hovering around 3 to 4%. So that's about a percentage point more than nationally. So we do have a larger opioid misuse problem here in Kentucky than we do nationally, unfortunately, but that's why we're talking about this today. So to briefly touch on the DSM-5 diagnostic criteria for opioid use disorder, patients do have to meet at least 2 of the following criteria within 12 months in order to meet diagnostic criteria for an opioid use disorder. And then severity is determined based on how many of those criteria they meet. From 2 would be the minimum, would be a mild opioid use disorder, moderate 4 to 5, and then severe would be greater than 6. So we have taking larger amounts of opioids over longer periods of time than intended, persistent desire or unsuccessful efforts to cut down on use, spending a great deal of time obtaining or using opioids, cravings or strong desire to use, problems fulfilling obligations of work, school, and home, continued use despite social or interpersonal problems, giving up or reducing activities because of opioid use, using opioids in physically hazardous situations such as driving, continued opioid use despite ongoing physical or psychological issues related to it, tolerance, so an increased need for opioids to achieve the same effect, and experiencing withdrawal symptoms from opioid use. So as far as opioid use disorder and co-occurring mental illness, which is going to be most of our patient population, over 20 million adults in 2024 had a substance use disorder and any mental illness, and then almost 7 million adults had a substance use disorder and a serious mental illness. This is from data from SAMHSA. Unfortunately, they didn't have a breakdown of just opioid use disorder, but you can see with substance use disorder there, it is still very significant. And adults with mental health disorders received over half of the total opioid prescriptions in the US annually. So we know that not half of all of the US has a mental health disorder, but they are receiving disproportionately more opioid prescriptions than anyone else. And they are significantly more likely to use opioids than those with mental health disorders, 18.7% versus 5% in the general population. So for medication-assisted treatment for opioid use disorder, we have 3 different options. Buprenorphine, which I'm going to cover in depth here in just a minute because that's what we have available here at Eastern State. Methadone, and then naltrexone. So we do have fairly extensive buprenorphine guidelines here at Eastern State Hospital. These are based on the guidelines from UK, and they were put together by Laura Plummer. Thank you, Laura. So buprenorphine is a partial opioid agonist, so you're not going to get as much of a effect, pain management, or otherwise as a regular opioid. Some of the formulations do contain naloxone, including the Suboxone that we use standard here at Eastern State. It doesn't have any effect when you're taking it orally, but it does kick in if the patient crushes it and tries to inject it intravenously. So that's when it's going to help discourage abuse or diversion. So our inclusion criteria are patients greater than 18 years of age, which is going to be all of our patients, reported use of an opioid or opioid use disorder. So you can discover that from their H&P if they have a history of medication-assisted treatment, their pharmacy records if they've been filling buprenorphine or methadone. So all of those patients would be appropriate for induction here. And they do have to be experiencing signs and symptoms of withdrawal as assessed by the COWS score. So since buprenorphine is a partial agonist, they do have to be in withdrawal, at least mild withdrawal, before you give them that medication, or it's going to automatically kick them into withdrawal. So our exclusion criteria would be altered mental status or decreased level of consciousness, severe acute pain or chronic pain on high-dose daily opioids. So because it's only a partial agonist, you're not going to get the same pain control that you would with a more potent opioid. So it's not going to be appropriate for those patients if they're already, seeing a pain clinic and requiring high-dose opioids. Buprenorphine's not going to be a good choice for them. And then documented hypersensitivity to buprenorphine, naloxone, or any component. So if they're allergic to it, obviously we're not going to use it. Here we have our signs and symptoms of opioid withdrawal, and these are going to be the things that we monitor in order to decide that they're appropriate to start induction. So we have our tachycardia, hypertension, hyperthermia, insomnia, yawning, dilated pupils, hyperreflexia, tearing, rhinorrhea, sweating, goosebumps, and muscle spasms. And then our symptoms are abdominal cramps, nausea, vomiting, diarrhea, muscle aches, and anxiety. And these are all going to be the things that we monitor with our COWS, our clinical opiate withdrawal scale. And this is our gold standard for assessing withdrawal. And it's going to be what we use to assess how a patient is responding to buprenorphine or our other medication-assisted treatments and whether they're ready to start treatment. So I won't go through all of these, but you can see that each one has a scale of either 0 to 4 or 0 to 5. And then in the bottom right corner there, you can see how we score it. So 5 to 12 is going to be mild. And if you remember before that I said we start buprenorphine when, excuse me, our COWS score is greater than or equal to 8. It's going to be mild withdrawal that we're looking for. So 13 to 24 is moderate, 25 to 36 moderately severe, and then anything above 36 is considered severe withdrawal. And these are our comfort care medications to manage the symptoms of opiate withdrawal. So for anxiety, we generally use hydroxyzine, 20 to 50 milligrams every 6 to 8 hours, max dose of 400 milligrams. For hypertension, tachycardia, and restlessness, we have clonidine, 0.1 to 0.2 milligrams every 6 to 8 hours. You do need to taper it if it's given for longer than 7 days, because if you give clonidine, especially scheduled for long periods of time, you can have rebound hypertension. But generally when we're treating withdrawal, it's going to be a shorter time period than that, so you don't necessarily have to worry about that rebound hypertension, just if it's longer than 7 days. You also want to consider hold parameters for the blood pressure. If it's less than 100/70, just don't give that dose of clonidine. For diarrhea, we have loperamide, so the standard dosing here still applies. It's a 1 one-time dose of 4 milligrams, and then 2 milligrams with each subsequent loose stool, a max of 16 a day. For our myalgias, you can use Tylenol or ibuprofen. Again, these are going to be short courses. This shouldn't last longer than a few days. Ondansetron, you can, for the nausea and vomiting, 4 milligrams every 6 hours if needed. We do have several formulations of this available here. We have straight up oral PO, we have orally disintegrating tablets, and then if the nausea is so bad that the patient can't keep anything down, we do have the IM formulation available. For muscle cramps, you can use PRN cyclobenzaprine or methocarbamol, 5 to 10 every 8 hours for the Flexeril, 750 every 6 hours for the methocarbamol, and then dicyclomine for the abdominal cramps. You can do 10 to 20 every 6 to 8 hours if needed. This is our ESH COWS protocol, so our clinical opiate withdrawal protocol. It is a nice way to kind of put all of those comfort care measures together, and it does have a scheduled clonidine component. So it's a nice, easy starting point for if you have a patient in opiate withdrawal. So it has 2 days of scheduled clonidine at every 8 hours, and then decreases to scheduled clonidine every 12 hours. And there will be COWS assessments scheduled in there as well. So if it gets above a certain point, so COWS greater than 12, which would be more into our moderate withdrawal, you can contact the provider for additional orders. It does also include some of our common comfort care medications in there, specifically the dicyclomine for abdominal cramps, the Vistaril for anxiety, the ondansetron for nausea and vomiting, and the loperamide for diarrhea. Some of the other medications, like the Tylenol, we do have already on our standard PRNs when they come in, so may not need to add those. So as far as when you induce, this is going to be dependent on what kind of opioid the patient is using. So if our shorter acting opioids are their drug of choice, heroin, the immediate release oxycodone or hydrocodone, you can generally start 12 hours after the last dose. For the extended release products like our OxyContin, MS Contin, you're gonna need to wait a little bit longer, generally 24 hours. And again, this is going to be based on that COWS score, so obviously not like a hard and fast rule. You still wanna make sure that their COWS is appropriate before you give that first dose of Suboxone. Now, our longest acting opioids, the methadone and fentanyl, particularly chronic high use, is probably going to be at least 72 hours. They're going to stay in the system a lot longer, and fentanyl in particular does store itself in the fat tissue, so it's going to stick around a lot longer. We're going to want to make sure that we have that appropriate COWS score before we start induction. So our laboratory evaluations, serum pregnancy test or serum or urine pregnancy test. Now, Suboxone is safe to use in pregnancy, so that's not necessarily going to stop us from using it, but we just want to be aware of that. Complete blood count, complete metabolic panel, urine drug screen, that's going to help us determine what kind of opioid the patient is using. HIV and hepatitis, these are going to be comorbid with a lot of our IV drug use, so we want to make sure we're getting those screenings at baseline in case we need to address those as well. But obtaining labs should not delay therapy. So if you have a patient coming in and they're not agreeable to labs or the labs aren't back yet, that doesn't mean that you shouldn't go ahead and start buprenorphine therapy. So here is a nice little flowchart of how you should induce. So at the top we have our inclusion criteria. Are they 18 years of age? Do they have an opioid use disorder, history of MAT? Are they currently using an opioid, abusing an opioid? And are they experiencing withdrawal? Do they have that appropriate COWS score of at least 8? If they do not, wait at least 60 minutes and reassess the COWS score. then reassess every few hours. They may not need buprenorphine. They may continue to have that lower COWS score. If it is yes, then you can go ahead and administer a Suboxone 4/1 milligram dose. I will talk about a little more about our available dosage forms later, but that's generally what we start with. And then you see if their withdrawal symptoms have improved. And after an hour, if they do still have that COWS of greater than 8, you can administer an additional 4/1 milligram dose of buprenorphine naloxone. And you can continue to assess every hour, see if they still have that COWS dose or that COWS score of greater than 8. And if they do, and that their dose of total daily dose of buprenorphine is still below 16, you can continue to administer those one-time doses. You can continue if you do on the second day still have a total daily dose lower than 16 and they're still scoring higher than 8 on the COWS, you can give additional 4 milligram doses in addition to that total daily dose. So the number of 4/1 milligram doses they require to achieve relief of those withdrawal symptoms is going to be their total daily dose of buprenorphine. Some special considerations: we generally do not recommend a daily dose of greater than 16 milligrams. That is been shown to be the dose that's going to control most patients' symptoms. As far as constipation, which is a common symptom of opiates, it can worsen if the film or tablet does not fully dissolve. So we generally recommend having the patient stay in the day room for at least 30 minutes after administration to make sure that it's dissolved, the film is fully been swallowed and everything. And it also prevents, sharing that film or tablet with other patients. If it's not fully dissolved, they could go hand it to someone else. We want to make sure that doesn't happen either. Our most common product that we're going to use for almost all patients is Suboxone, which is the buprenorphine naloxone film. We do have 8/2 milligram, 4/1, and then we do actually also have 2/0.5. That's going to be standard. We do have the tablets, the sublingual tablets as well. They're not our first choice, but for example, I had a patient a few weeks ago who wasn't able to tolerate the film. The taste made them gag, so we were able to use the tablets for them. We do also have plain buprenorphine. In the past, it was the recommended product for pregnancy. Those guidelines have changed, so now it is been determined to be safe to use the combination product in pregnancy, but we do still have the plain buprenorphine available for patients who have some sort of intolerance to the naloxone portion. And then for our chronic high-use fentanyl patients or methadone patients, since those are going to take longer to get out of the system, you may want to consider using that lowest dose for your first initiation, the 2/0.5 milligrams, and aim for a higher COWS score just to make sure that they're completely into withdrawal, because they're going to have a much higher likelihood of the buprenorphine kicking them into withdrawal with that first dose. So I will give the caveat that we unfortunately do not have these products available at Eastern State on the inpatient side currently. I know that the long-acting injectable clinic here has been working on getting these on their formulary. I'm not sure where they are on the availability for those, but they will be a potential here in the future. There are 2 different buprenorphine long-acting injectables available on the market currently. Both products do have a REMS program through the FDA, so that's a risk evaluation and mitigation strategy. That is a program where the FDA strictly monitors distribution of these medications in order to mitigate serious side effects. So specifically for these 2 medications, the concern is the medication getting into the hands of the patient and them trying to inject it intravenously, which can cause serious harm or death. So these medications will never be distributed directly to the patient. They'll always go straight from the pharmacy to wherever the patient is receiving the injection. The first one is Sublocade, which is a 300 or 100 milligram sub-Q monthly injection. The initial dose is going to be 300 milligrams, and then 1 to 3 days after the initial dose, you can give an additional 300 milligrams based on patient response. If they're still in withdrawal, if they're tolerating the first dose, they can have that second loading dose. And their maintenance dose is also going to be decided based on their response and their withdrawal symptoms. So if they're, not having as much withdrawal, they're tolerating the initial doses well, you can start with the 300 milligrams, but if they're still having withdrawal, they're still having more cravings, you can go to the 300 milligram monthly. Brixadi is a little bit more variable in its dosing, so it does have 2 different dosing strategies. There is a weekly sub-Q injection, which is only for those, it's either for those not currently receiving buprenorphine, or it can also be for patients who are currently receiving buprenorphine. However, the monthly dosing is only for patients who are currently receiving buprenorphine. So in order to initiate Brixadi for a patient who's not been on buprenorphine before, you're going to give them an initial 8 milligram sublingual dose, and then load them on a 16 milligram injection. And then over subsequent days, additional 8 milligram injections can be administered, up to 2 of those based on their response and their COWS score. So 32 milligrams weekly is the maximum dose for the weekly dosing, and the monthly dosing is 64 to 128 milligrams. So you can, once the patient is on the weekly dosing, you can end up switching to the monthly dosing, and that's just going to be a straight conversion. I don't have the dosings laid out, but there is a straight, like, this dose converts to this dose. And for patients who are already taking sublingual buprenorphine, there is a straight conversion from that to the dose of either the weekly or the monthly Brixadi as well. Now I'm going to talk about methadone. Methadone is a much longer acting opioid agonist. We unfortunately do not currently have this available at ESH. But we do see quite a few patients come in on it, so it is still important to discuss. It is only available outpatient via opioid treatment programs, specifically for OUD. Now, I will caveat this with, we do see a lot of issues with this not necessarily appearing on a CASPR. There have been recent updates in CASPR where it will show if a patient is in an opioid treatment program, but I've not seen this be terribly consistent. So if you do have a patient come in on, say they're on methadone and their CASPR comes up blank, that doesn't necessarily mean they're lying. We will generally contact wherever their treatment program is to confirm the daily dose and help us decide a plan of action depending on how long they're going to be here, how much methadone they're on, things like that. So generally, at first, when a patient starts methadone, they're going to be going into this treatment program every single day to get their individual doses. Once they've been on it for a while, they've made progress in their treatment, and they're low risk for diversion, they can actually get some supplies to take home with them for a few days, a week, something like that. One of the big things we have to be considerate of for methadone is the potential to cause arrhythmias, specifically QTc prolongation. So if you were to initiate a patient on methadone, this is something you'd want to be cognizant of. We're going to get an EKG at baseline. For most patients, I think most patients here would meet one of these criteria. So if you have a prior EKG with a QTc greater than 450, if you have a history of arrhythmias, if you have a family history of cardiac risk factors, abnormal LFTs, electrolyte abnormalities, or other QTc prolonging meds, and with our psych patients, that's going to be most of them because a lot of our psych meds have the potential to prolong the QTc. If a patient does have an EKG with a QTC less than 450, you're good to go with starting methadone. If the QTC is between 450 and 500, that's going to be a risk-benefit discussion, excuse me, with the patient and the provider. And if the QTC is above 500, then that's a non-starter for starting methadone. You're going to repeat the EKG in 30 days, and then annually if the dose is greater than 120 milligrams. So our dosing is not necessarily going to be super hard and fast. Your initial dose is 10 to 50 milligrams, depending on the level of physical dependence, up to the discretion of the provider. You do want to consider a lower starting dose, 2.5 to 10 milligrams for patients who have low or no opioid tolerance. So this is going to be your patients who, you know, maybe have been off opioids for a number of years, but they just had a relapse. Or if you have a patient who's been in prison where they don't have MAT available to them, but they get out and they want to restart treatment. Those are going to be your patients where you'll consider a lower dose. Because it does have a very long half-life, you do titrate it very slowly, so no more than 10 milligrams every 5 days. And this is going to be based on withdrawal symptoms and sedations. We can use blood levels to assess safety and efficacy. And then when you're looking at their total daily dose of methadone, our lower doses usually aren't going to cut it. Most patients are going to require 60 to 120 milligrams for a maintenance dose, and some patients need even more than that. So lower doses, not super common. Other considerations, you're going to want to monitor LFTs. EKG we already discussed. You do want to get a pregnancy test. Methadone is safe in pregnancy. It is generally regarded as the #1 opioid medication-assisted treatment of choice for pregnancy, and then you can potentially get serum levels. Now, we do want to keep an eye on our drug interactions. So because methadone goes through the liver, it has a lot of CYP 450 drug interactions. It is a minor substrate of most CYP enzymes, so particularly 2B6, 2D6, 3A4. So if you have inhibitors or inducers on board, you want to keep an eye on that. And it is also a minor inhibitor of 2D6, so that's something to also consider if you have other psych medications on board that go through 2D6, for example, our Risperdal or our Abilify. It could increase concentrations of those. So since we don't have methadone currently available here, I do want to briefly discuss transitioning to other medications. We do have several options. None of them are necessarily great options, but you can transition from methadone to buprenorphine or methadone to naltrexone. And this is going to be largely patient specific based on, you know, how long you think they're going to be here, what dose of methadone were they on, you know, do they want to transition to another medication? But this is all going to affect our decision making. Now, if they're going to just be here for a couple days, because methadone has a really long half-life, we can usually just let them kind of ride it out and then follow up with their outpatient methadone clinic to resume that methadone dose. If they're going to be here for a longer period of time, we may want to consider transitioning to something else. So buprenorphine, it's going to be a little bit more of a difficult transition. Since it is a much longer acting opioid, it's going to take much longer to get out of the patient's system. You do have to be a little bit more careful with it. It's going to be more uncomfortable for the patient because it's going to potentially kick them into more significant withdrawal. So you want to wait until they're experiencing mild to moderate withdrawal. We're generally going to recommend following our buprenorphine induction guidelines, just with the caveat that you might want to wait for that little bit of a higher COWS score of around 12, just to make sure that they have the majority of the methadone out of their system first. Also, you may want to consider the lower initiation dose of 2 milligrams just to make sure that they are fully in withdrawal. Naltrexone, this is going to be more for our patients who just don't want to be on an opioid anymore. Most patients aren't going to be necessarily a fan of being completely off an opiate to be on naltrexone, and you do have to be completely withdrawn for opiates prior to initiation, so at least 7 days from the last dose. And you can give a test dose of either oral naltrexone or naloxone to confirm the patient is completely free of methadone and no longer in withdrawal. So this is a very large chart of opioid conversions. I do want to talk briefly about transitioning from methadone to another opioid. So this isn't necessarily straight out of the guidelines, but it is something we have done here in the past, specifically if a patient is not going to be here a super long time, but long enough to still need to be on something, and they're going to go straight back to their methadone treatment program and resume that. They don't necessarily want to transition to another MAT treatment like buprenorphine or naltrexone. You just kind of want to keep them maintained until they can go back to that methadone treatment program. So I do want to give the caveat that, you know, for most opiates, you can use those online conversion websites and it'll spit out the conversion and it's totally fine. That is not the case with methadone. It does not have linear kinetics, and the conversion changes based on higher methadone doses. So if you try to put it into one of those online conversion applications, it's not going to give you an accurate answer. It will probably give you an answer that scares you very much, honestly. So you can see here when you look at the methadone conversion, so we want to go, say, from methadone to oxycodone. So if you look here, at first glance, it looks like the methadone is directly equivalent to the oxycodone. They're both at 20 milligrams equivalent dose. That is not true, unfortunately. So if you look further down at the bottom, and you want to convert everything to morphine equivalents, you're always going to convert to morphine equivalents when you're translating between different opiates. So I'll use an example I saw not too long ago. So I had a patient who came in on 180 milligrams of methadone. So if you convert that to morphine equivalents, go from 20 to 30, so that's going to be 270 morphine equivalents. We're obviously not going to give someone that much. But if you look down at the bottom, we have these conversion factors. So if you look at the range, 100 to 299, that it falls in that 8-to-1 conversion factor. So if we divide the 270 by 8, we get around 30. So 30 morphine equivalents is about equivalent to 20 milligrams of oxycodone. So you can do 5 milligrams QID of oxycodone, add an additional maybe 5 BID PRN for breakthrough withdrawal symptoms. So it can be a confusing calculation. Feel free to always contact your pharmacist if you have questions. But yeah, methadone is a little less straightforward than converting to other opiates, but that might be the most reasonable way to maintain patients while they're in the hospital if you don't want to go through the steps of converting them to different medication-assisted treatment. So I'll discuss naltrexone briefly. It's not going to be our #1 choice. It is an opioid receptor antagonist. It's going to completely block the effects of opioids. It does have 2 dosage forms. We do have oral naltrexone available here. It is unfortunately not recommended in the guidelines because it often lacks effectiveness due to adherence. It is something that patients have to take every day, and it's going to, it can help reduce cravings, but the IM monthly formulation is preferred. And really naltrexone is going to be for a patient who, just wants something to help with cravings and they've been off opiates for a longer time. They really don't want to be on an opiate anymore. We unfortunately do not have Vivitrol, the IM formulation, available here on the inpatient side, but it is available at our LAI clinic. So if you have a patient here who has been on oral naltrexone inpatient, they're tolerating it well, they want the longer acting formulation, you can have that administered at discharge via the LAI clinic. And really our biggest monitoring component here is going to be LFTs. So naloxone is our IM or nasal formulation opioid receptor antagonist. We use it for overdose reversal. We do have the nasal spray formulation, the 0.4 milligrams, available on all the crash carts here at Eastern State. And we do also have it available for dispensing at discharge. So we receive our supply for free via the core naloxone grant. So that's Kentucky Opioid Response Effort. So we're very lucky to be able to have that supply available for dispensing to patients at discharge free of cost. And we want to target any patient with a history of substance use disorder. With the rates at which our drug supplies are adulterated these days, it doesn't matter if a patient doesn't have a history of opioid use disorder. Really, any drug that they're using illicitly can still have the potential to be adulterated with fentanyl or another illicit opiate. And we do require, it does have to be written as a discharge med on the discharge order because we do track demographics for patients who do receive naloxone here at discharge. So that's how we track those. We also have nalox boxes available within ESH. So there's one located in admissions and one located in InPath. So these are for patients who aren't necessarily admitted here. It does not require a prescription in order to hand out. So anyone can take a naloxone from those boxes. And this is going to target our patients who, you know, have a substance use disorder, but they're not admitted here. And really anyone can carry naloxone. It's over the counter now. First responders carry it. Really anyone who has a friend or family member, loved one with a history of substance use disorder, it's a good idea to be carrying naloxone and know how to use it, because it's not generally going to be the patient who overdoses who's going to be administering the naloxone. So this is our flyer that we give out with naloxone at discharge. It shows the steps to go through if you have someone near you who you think has overdosed, how to check for breathing, how to administer the naloxone, to call 911, do the rescue breathing, and then who is at risk for overdose with opiates. So this is our kind of quick and dirty education that we give the patients. And there are also instructions on each box of Narcan on how to administer it appropriately. So co-occurring psychiatric disorders, and all of these recommendations have come from the American Society of Addiction Medicine. So all patients should be assessed and monitored for suicide risk. These patients are going to be, you know, more at risk because they do have access to means if they're using illicit medications. An assessment of psychiatric disorders should occur at the beginning of treatment, but should not delay or preclude initiating pharmacotherapy. So we should also always be assessing psychiatric disorders in addition to our substance use disorders, but if a patient is not interested in psychiatric treatment at that time, you're not necessarily going to withhold treatment for OUD. Again, pharmacotherapy should be in conjunction with psychosocial treatment, should always be offered together. This is going to be seen in a lot of our opioid treatment programs, like methadone treatment programs. Psychosocial treatment is always going to be offered, but should not prevent a patient from getting opioid use disorder treatment if they're not interested in psychotherapy at that moment. And then specifically for our patients who have co-occurring schizophrenia with their opioid use disorder, ACT or assertive community treatment should always be considered for these patients as an extra safety net, because they're going to be most at risk for repeated hospitalization and homelessness, and we want to give them that extra support. So in conclusion, adults with mental health disorders are significantly more likely to use opioids than those without mental health disorders. Our main pharmacological treatment options are buprenorphine, methadone, and naltrexone. We unfortunately only have buprenorphine and naltrexone currently available at ESH, and buprenorphine is going to be our preferred treatment measure in most cases. And then we should be distributing naloxone to any patient with a substance use disorder at discharge. Does anyone have any questions?